Sure. Audible? You're muted.
Now, ma'am. Audible.
Good evening, sirs. Slides ready இருக்குல்ல?
Yes, ma'am.
Good evening, sir.
Hello, Madam Kalpana. How are you, ma?
I'm fine, sir. Good evening, sir. How are you, sir?
Fine, fine. Thank you. Thank you. I'll join. Yeah.
Good evening, sir.
Good evening, all of you. Good evening, sir.
Good evening,
Good
sir.
evening, Bala. Good evening, madam.
Good evening, sir. Good evening, sir.
Good evening.
Good evening, sir. Dr. Bala, sir. Good evening.
Good evening, Dr. Ramakrishna.
Good evening, ma'am. Dr. Kalpana, ma'am. All the best, Dr. Aishwarya. Right.
Thank you, sir.
We'll wait for a minute and then we'll start. Okay, sir? Whether
Yes.
Subramaniam or may join.
Relax. You look a little tense. Yeah, smile. Yeah, good.
Nice that you are joining regularly. It adds a lot of value.
Ma'am, are my slides visible now?
Yeah, very
sure.
visible,
sharing.
visible. Yeah.
You may just
Yes.
stop sharing.
Yes, sir.
You may share it again after a minute.
Okay, sir.
Okay, sir. Shall we start? Good evening, everyone. I welcome Dr. Srinivasan, Dr. Bala Subramaniam, sir, Professor Kalpana, ma'am, Dr. Aishwarya, and all the attendees who have joined to get enriched with today's presentation and case discussion. I thank Central IAP, headed by Dr. Kinju Vadekar, and AAP for facilitating this. And I request Dr. Bala sir to give some opening remarks.
Yeah, thank you, Dr. Ramakrishna. I don't think I should be wasting time. All I have to tell you, Dr. Kalpana is a very, very good clinician with very strong fundamentals in pediatrics, very keen to teach. I'm sure we'll have an exciting session today. Over to Dr. Kalpana and the presenter, Dr. Aishwarya. Thank you very much, Dr. Ramakrishna.
Right, sir. Dr. Professor Kalpana.
Yes, sir.
She is head of the department in Government Vellore Medical College. And as Dr. Bala sir was telling, she is a very good clinician. That's why we selected her. And now we will see enlightenment that is disseminated from Professor Kalpana. And I wish you all the best, Dr. Aishwarya. You may start presenting the case.
Kalpana, madam, it's a sister while you have been this thing. So you have to be very happy.
Thank you, sirs. Thank you. Thank you, teachers, for whatever, for the kind words.
Yes. Dr. Aishwarya, proceed.
Good evening, sir and ma'am. I'm here to present a case on anemia with hepatosplenomegaly. Here, here is A 2-year-old, 3-month-old, 2 years, 3-month-old girl child, third born out of non-consanguineous marriage, whose informant is mother and whose reliability is good, has come from Anikat in Vellore district.
Go on, Aisha.
History of presenting illness of this child. The child is a known case of hematological disorder, has come for her due transfusion. The child was apparently normal up to 7 months of age and had a history of hospital admission at 8 months age. When mother noticed pallor compared to her siblings, child was admitted for complaints of fever for 3 days, cough and fast breathing for 2 days. On admission, she was treated with oxygen, IV medications, and given blood transfusion after investigations. Parents were counseled that the child may require repeated blood transfusions. The siblings and parents were screened and found to have milder form of the same illness.
Dr. Aishwarya, what are the complaints? Did I miss it? Present complaints.
Presenting complaints, mother had noticed pallor for the past 1 month in the child.
No, presently. Okay.
At present, the child had come for her due transfusion, sir.
No, sir, that is there, but there will be some symptom, isn't it? Was there any symptom? No symptoms at all.
No,
Right.
sir. At this presentation, the child did not have any specific symptom, but
Okay.
at the diagnosis or in 8 months of age, she
No,
had
no,
these
that is there. As per advice, she has come, not with any
Yes.
symptoms.
Yes, sir.
Okay, this time. That's why you are not mentioning complaints. Okay,
Yes,
right.
sir.
Okay, carry
So
on.
Aishwarya, this child has come for a child who's known case of hematological disorder who is on regular transfusions. Would you like to comment on her place of residence? Where is she coming from? Is it a hilly area or it is a plain? Does it have any significance for a child with chronic anemia?
No, ma'am. The child is not from any hilly region. It is a plain only.
Okay. Do they have any significance, a place of residence?
Yes, ma'am. There are certain areas regarded as thalassemia belts.
What are the thalassemia bells in your state, in our state?
No, be cool. Don't be tense. Right? All of us are
Dharmapuri,
here to
Salem,
support you.
Namakkal,
Salem.
and certain parts of Tiruvannamalai and Vellore, these are prone to have, they're known as thalassemia bells. And
Yes.
central and northern India also are known to have a lot of thalassemia, high thalassemia carriers. Why do these areas have high thalassemia carriers? Well, this amount of carriers are not present in the developed world or the Caucasian population. In some of these areas, the carrier state is as high as 50%. Why do you think nature has put them in that? Is it a disadvantageous position or it is has some advantage? For hemolytic anemias, why it is common in children who are born in tribal areas?
Ma'am, you may tell to save time.
Okay, it is because of the high degree of inbreeding or consanguinity which is present in this tribal population. But more than that, these hemolytic anemias, they give an inherent or evolution has given us an inherent resistance to malarial infections. So most of the areas where malaria is endemic, evolution has made us most of them as thalassemia carriers. So they can have some resistance against malaria. So most of you, the tropical areas where there is hilly and tribal areas with lots of rain, mosquitoes and malaria endemic regions, the amount of thalassemia carriers are also very high. Especially sickle cell is very high in tribal areas. So the place of region is very, very important. And now with cosmopolitan, suppose a child comes from the northeast, what type of abnormal hemoglobins are very common in the northeast? Hemoglobin E. So child comes from a northeast, just remember that this could be a hemoglobin E variant. So the place of residence is very, very important, especially communities also. Some of the communities have a higher prevalence of thalassemia carriers in them. So you have to have a little more history on which is the place, whether it is a hilly or tribal areas and what is the incidence of thalassemia in that location. Okay. So this was her complaint at 7 months of age. Can you give some more information on this?
On presentation, the child was found to be tachypnic.
Yes.
How
do you know that child had just a pneumonia or the child had congestive cardiac failure? How long did the mother notice pallor before the child had come to the hospital?
Pallor was noticed for the past 1 month,
Okay.
but the child was brought to the hospital actually for complaints of fever and cough for 3 days.
Okay. Is it usual? Is it the usual presentation?
Um,
It
Yes,
can be
ma'am.
normal
It
also
can-
because
it
it's just a chronic anemia. The child will be well compensated. But a sudden respiratory tract infection can increase your congestive cardiac failure or symptoms and bring the child to your to medical care. But what other history can you ask the mother to say whether the anemia was severe or was long-standing? What other history you can ask proactively?
If not in this infant, in a little grown-up child.
History of irritability, lethargy.
Okay, irritability, lethargy will occur in severely anemic children. Other than that, the child is well, is in the house, it is not brought to the health care system. If the child was irritable or lethargic, the mother would have brought the child immediately to the hospital. What else could have been there in the child? How will you ask for a history of exercise intolerance in a 2-year-old child
That's what I'm asking.
or
little
a
older child.
7-month-old child?
Sucrose cycle on direct breastfeeding.
Okay. Other than that?
Forehead sweating will be there.
Okay, then. Very good then. For a 2-year-old, how will you ask for exercise intolerance?
Does the child interrupt while playing?
You said the child had absolutely no symptoms, but maybe even be anemic. So even if the child does not have obvious pallor, then how is the child playing? If the child is willing to move about, interact with other, or is just willing to sit and play? So that should be a proactive question to ask for exercise intolerance. You cannot ask a mother whether the child develops dyspnea on running or the child develops dyspnea on climbing upstairs. That is not going to happen in a 2-year-old child. So these subtle questions that we asked to bring about a history of exercise intolerance. Other than that, if the child has congestive cardiac failure, what other symptoms you can ask the mother?
Swelling of feet.
Yes, yeah, very good then.
Abdomen distension.
Okay, then for congestive cardiac failure, a 7-month-old infant. Whether the child has increased precordial activity when the mother holds the child against her chest, whether she feels the chest pumping or there's increased rate like that, or there is mild facial puffiness or mild edema of the feet or puffiness of the feet, the mother must not have noticed. But when you ask for proactively, the mother will come out with these symptoms. So this is a chronic anemia. The most important complaint will be easy fatigability and exercise intolerance. But if you ask the question directly, whether the child is easily fatigued or has exercise intolerance, it will be negative. You have to ask in ways that the mother can understand. So all these histories should come in even in your presenting, in your past presenting complaints in your 7 months of age. Okay, go on.
Dr. Aishwarya, apart from breathlessness, that is heart failure, what else can restrict the activity of a child? Say around 3-4 years. What else restricts the child's active play?
Apart from anemia, sir?
Yeah, in this child presenting like this. Ma'am has already answered the question, that is fatigability. Fatigability is such an important symptom that we have to look into. Okay. So even though the child may not have symptoms of congestive heart failure, still there may be some limitation of activity because of fatigability. What are the 2 important causes of fatigability? Easy fatigability.
What
in this
system
case, what causes
does it
fatigability?
localize? Easy fatigability, what system does it localize to?
In this case, what is the cause for
cardiovascular
fatigability?
system.
No. In this case, what is the cause for fatigability? When there is no congestive heart failure.
In this case, what is the cause of easy fatigability?
Hypoxia.
It is because of anemia and hypoxia to the muscles. So easy fatigability localizes to the muscles. So other than oxygen, what else the muscle needs?
What else can cause fatigability?
Storage disorders leading to hypoglycemia.
No, before, not hypoglycemia. See, one is oxygen carrying capacity. When it is low, it causes tissue hypoxia. What else causes tissue hypoxia?
Anemia causes hypoxia. What else causes hypoxia?
What else can cause? One thing is related to oxygen carrying capacity. The other one is related to perfusion.
Perfusion.
The perfusion is low, that causes fatigability. Which heart diseases are likely to cause fatigability more common than other heart diseases?
Similarly, any chronic lung disease, when the child has any chronic disease and there is hypoxia, again the child will have EC fatigability. So all this are differential diagnosis for EC fatigability and exercise intolerance. So you have to ask and rule out each of these before you localize it to the hematological system. But of course, the mother has also noticed a significant pallor when compared to the siblings. So you can attribute the EC fatigability to the pallor, okay, to the anemia as such. Okay, okay, go on.
History of presenting illness. There was no history of yellowish discoloration of eyes, no history of abdominal distension, no history of hematemesis, melena, or hematochezia, these amounting to blood loss that can be the cause of anemia, no history of hematuria, no history of puffiness of face or reduced urine output, leading to which can rule out the renal causes of anemia, no history of fever with chills. This rules out infectious etiology, malaria as the cause of anemia, no history of recurrent infections or bleeding manifestations. It is not suggestive of malignancies. There is no history of loss of weight. There are no history of seizures. There is no history of painful digits or leg ulcers. There is no history of swelling of feet at present, and there is no history of delayed attainment of milestones, and there is no history of pica or no history of passing worms and stools, but there is history of recurrent blood transfusions.
Recurrent means how many times?
Once in how many days?
Regular transfusions once in 21 days. As of now, up to 15 times, sir.
Now, is there any shortening of the interval between two transfusions over months?
No, sir. It was all regular every 21 days.
As per plan, they are going.
Yes, sir.
Okay, right.
Yes.
Suppose there is sudden decrease in the interval between two transfusions than expected. What it can be? Because of, or you will answer later. It's your take. Suppose the plan was around every 4 weeks, and suppose the baby may require transfusion within 15 days. What would have happened to the girl or the boy?
Acute stressing event in form of infections.
How will that cause increased transfusion requirement? What can cause the worsening of hemolysis? That is what sir is asking. A child who is requiring transfusions every 3 weeks, a chronic child, suppose the child is 7 or 8 years old, now is requiring transfusions every 2 weeks. What could be the probable reasons? So one is because of hypersplenism. So as the child grows and is inadequately transfused, there is extramedullary hematopoiesis and the spleen size is quite high. That can cause hypersplenism and reduce your duration of transfusion. It can break down the cells furthermore. Second is there could be some alloimmunization with minor blood group antigens incompatibility.
Right.
So that will be an important cause for frequent transfusions. And third, in all these bone marrows involvement, we should always keep parvovirus infection in mind. Although it is not very common in thalassemia, suppose a child has very frequent transfusion, think about an parvovirus infections also. But coming to your history, how will you approach anemia? That is a child who's anemic, who's got regular blood transfusions. First, we have to localize what is the type of anemia. From your history, what is the type of anemia that you are pointing out?
Just before that, don't you think there is some paradox in saying that there was never history of icterus? Did you ask probingly?
Yes, sir.
Sometimes when it is a long-standing thing, the parents they're accustomed to seeing that light yellow tinge of the eyes, they may not notice that it is icterus. Unlike in a case of viral hepatitis, they come out with the history of yellowish discoloration. When it is long-standing, they get used to it. They think that it may not be icterus. unless you ask probingly, that means suppose you find icterus, then you can go back to the history and ask whether the eyes were like this all this 1.5 years. If it is so, that means the child was having icterus. You expect icterus to be there, isn't it?
Yes, sir.
Right.
Some
So whenever history is not supportive of the findings, you may go back and specifically ask probingly, right? Yes.
um,
And
From
you
what
have
type
nicely
of
brought
anemia
out
is this?
various causes for anemia. That's good. Right.
Broad classifications. I'm not asking individual causes. Broad classifications which you can get from the history. What can cause anemia requiring regular blood transfusions?
yes, ma'am. Anemia can be of due to decreased production and can be due to blood loss or due to hemolysis. From this history, we are able to rule out the causes of anemia which are due to acute blood loss, and the history is not also suggestive of hemolysis.
So what history will point towards hemolysis?
There would have been history of abdomen distension, ma'am.
Okay.
And
so 2-year-old or a 7-month-old, okay, there must be history of abdominal distension, and if a history of jaundice is present at presentation, probably that will point towards hemolysis. Although jaundice is not commonly seen in children with thalassemia unless in certain conditions. So if there is a significant abdominal distension, what the mother must have noticed during bathing, in that case, or if there is significant jaundice in the presence of recurrent or monthly transfusion, it could be probably hemolytic. Can it be because of decreased production?
in this case, there is no history suggestive of decreased production of hemoglobin.
Why? There is no abdominal distension according to the mother. There is no history of jaundice according to the mother. So still it can be because of decreased production, like there is some cause which will require recurrent transfusions.
In a very young child.
In a young child, in a 6-month, 7-month-old, what are the causes that can produce recurrent transfusions?
When we say very young child or infancy, you think of conditions which are
Congenital, no? Congenital or genetic.
Okay, think of congenital. We are stressing that very young child.
Hereditary spherocytosis.
That is hemolysis. That will be history of hemolysis. Other than decreased production, it can be because of bone marrow failure like Fanconi. Again, Fanconi will not be presenting so early. It can be some of the congenital anemias like Diamond-Blackfan syndrome and congenital dyserythropoietic anemias. Still, that can be a possibility from this history because there is no history of abdominal distension or hemolysis. So that is because of decreased production. Although iron deficiency anemia will not require these regular transfusions, you can look at certain causes like malabsorption. But again, a regular transfusion, monthly transfusion is quite unlikely. So that is why you put pica and all that. You haven't put pica and all that. Okay. Malabsorption, constipation history, some chronic systemic illness that is producing anemia of chronic disease can also produce recurrent transfusions, but it won't be this frequent. So here, according to your history, either it can be there is anemia because of decreased production or there is because of increased hemolysis. These two are the possibilities. Okay, go on. Why did you ask for history of loss of weight?
To rule out malignancies.
No, don't go for big things.
Loss of weight.
Need not go for big things, uncommon things. Think of common things.
Malnourishment.
See, what is the child is recurrently exposed to hypoxia. What does it cause?
Growth retardation, sir.
That's it. You relate to the present scenario instead of going for presumptions. Okay.
More than loss of weight, failure to gain weight adequately when compared to the other siblings or to the peers. So that will be an important history in children with thalassemia because of the chronic hypoxia, especially if they are not properly transfused. Okay.
Yes, ma'am.
Why did you ask for history of
just a minute.
seizures? Previous slide. Why did you ask for history of seizures?
To rule out storage disorders as the cause of anemia.
Okay, which storage disorder can produce recurrent transfusions? with seizures. Okay. Storage
Gaucher's
disorder.
disease.
Gaucher's. In Gaucher's type 1, there won't be any neurological manifestation. They can just present at heterosplenomegaly and sometimes even anemia recurrent because of hemolysis, hypersplendism, all that. So it can be storage disorders. So once you have ruled out, you've come to these two conditions, that is hemolysis or anemia of decreased production. You have to come and ask now differential diagnosis for increased destruction or decreased
storage
production.
disorder like Gaucher's need frequent transfusion.
No, again, Gaucher's, again, your storage disorders will not require such amount of monthly transfusions. As Sir has pointed out, it's very unlikely. So the second thing is etiology of the hemolysis. What etiologies can you rule out from your history or you have ruled out?
No, come to
Etiology
the
of
second line. Come to the
hemolysis.
second line. Painful digits, leg ulcers. Why did you ask for? That's what ma'am is asking.
These are suggestive of sickle cell anemia
Yes.
and its complications.
Okay. When
Swelling
is
of
sickle cell anemia present and how does it present? Will it present like this with recurrent transfusions?
It will be an acute crisis presentation. And
What is the usual acute crisis does occur in sickle cell anemia?
age of
And what
onset.
is the age of onset and what is the common mode of presentation? It is there in your, the answer is there in your slide.
Usual presentation is only beyond infancy.
So it will present beyond, before 2 years, from 6 months to 2 years. And usual presentation is dactylitis, painful digits. That will be the usual presentation. Or in the form of crisis like abdominal pain, chest pain, or long-standing they can have leg ulcers. But painful digits is the usual presentation of sickle cell anemia. Again, they will not require or they will not be put on regular blood transfusions like thalassemia unless they had presented with some neurological manifestation. Otherwise, sickle again will not be put on regular blood transfusions. Okay. What other history you can ask to find out the cause of hemolysis?
Any specific drug intake following which the child had symptoms?
Okay, okay. So that will be, they won't be put on regular prophylactic transfusions, but suppose there are recurrent transfusions requirement following some exposure to drugs, you'll think of, why did you ask that history? Drug exposure, why did you ask?
Certain drug exposures precipitate cases of G6PD deficiency.
G6PD deficiency. So it is not the other, it is the other way around. So exposure to the drug causes acute hemolysis and the child will be transfused. So here the child is on prophylactic transfusions. So this again is not likely to be G6PD deficiency. Why did you ask history of swelling of feet? So club your history. Club your history. You wanted to ask it for congestive cardiac failure. So that must have come earlier. And seizures, delayed milestones, or any floppiness, all those are suggestive of storage disorder. Again, less likely to require regular transfusions, but you have to combine. And pure iron deficiency anemia, what is the usual age of presentation? Simple iron deficiency anemia.
6 to 24 months. If they
So early,
it is
if they present at 6 months, it is usually 9 months. Because our stores, if the child was otherwise normal, there was no NICU admissions, our stores will be adequate till 6 months. But if the mother had not started proper weaning, then the child will have symptoms of iron deficiency or develop overt iron deficiency only around 9 months to 24 months. So that is the usual age of presentation of iron deficiency anemia. But if iron deficiency anemia was subsequent to some chronic disorders, probably they might have required like regular transfusions. What worms will cause iron deficiency anemia? What worm infestations?
Hookworms are
Hookworms
most common ones.
Trichoria. All these will produce bleeding and iron deficiency anemia. Of course, not requiring so many transfusions.
Yes.
Just a minute, Dr. Aishwarya. Dr. Balasubramanian, sir, your comments.
Extremely very good history. But I think history should be focused. See, here is a child who has received nearly about 11 transfusions. Am I right, Dr. Aishwarya?
Yes,
11.
15.
Yeah, 15 transfusions. And that means it is a chronic
Transfusion.
anemia.
Yes,
Chronic anemia. And this is a chronic anemia in which I would only ask for few very important symptoms. For example, a child who requires 15 transfusions, straight away a few diagnoses are not there.
yes.
Can you tell me which are the diagnoses which are not there in this child first? And I won't talk about it at all. Please tell me, Aishwarya. Some diagnoses straight away not there. 15 transfusions in a child who's 3 years old. Some diagnosis straight away not there. Tell me which diagnosis is not there.
For some, what you've asked history also.
You know, how many times anybody will receive blood transfusion for a deficiency anemia?
Yes, sir. Nutritional causes.
Never. So straight away, this is not a nutritional anemia. But even if there is an underlying cause for the nutritional anemia, the underlying disease will be more obvious than the anemia. But I have not seen any iron deficiency anemia requiring 15 transfusions in 2 years. One.
Yes, sir.
Second, I think worm history, even in the last session, I said the same thing. Worm history is of no use in a child who has received 15 transfusions. Your hookworm is never seen in the naked eye. There is no question of worm infestations causing any anemia like this requiring 15 transfusions. Straight. So when you talk about negative history, it must always be something which is relevant. But what is interesting is that I never heard, you should have stressed that there had never been any jaundice at any point. Yes or no? Did you mention that? Yeah. I think that's the most important history. What does that tell you? There are 2 children who require repeated transfusions. One child has persistent or recurring jaundice. The other child doesn't have overt jaundice. What is the difference between the two? And give a clue.
Intravascular hemolysis.
Intravascular?
Hemolysis. A disease with intravascular hemolysis.
Okay. What is the difference? No, what I want is children who are requiring transfusions repeatedly. One of them has persistent jaundice or jaundice which is very obvious most often. The other doesn't have jaundice at all. What is the difference between the two? That's what is my question.
The child has recurrent transfusions and jaundice. What could be the possible etiology?
Yeah. In contrast to somebody who doesn't have
recurrent transfusions and no jaundice.
Hereditary spherocytosis is one presentation.
Broader. Make it broader.
Yes. So again, absence of jaundice straight away in this child rules out hereditary spherocytosis. Yes or no?
Yes,
and
sir.
hereditary spherocytosis does not require periodic transfusion like this.
Yes, sir.
Child. That is point number 2.
Yes.
The third point is, I never heard at any point of time whether there was any abdominal distension in this child or not. You
She
talked
said
only
no
about
history.
in the history, did you mention anything about abdominal distension? Why am I asking about it?
Yes, sir. Abdomen distension, mother did not notice when I was asking for the history. She could not say any abdomen distension, sir.
Mother did not notice. Okay. Always, as usual, we are putting the blame on the mother. But on examination, you find positive findings on abdomen, you found distension, isn't it?
Yes, sir.
You could have gone back. That's what. Again, students must know. There's no harm in asking history after you finish the examination. You can change your history. The mother can be easily pointed out, can be asked whether distension or not. And you can point out, when did this happen? And I can tell you, most mothers will tell you that there is distension which is more in the left side than in the right side. And even from the history, you could have made out that this is splenohepatomegaly. After you have put in the title itself, it's anemia with hepatosplenomegaly. So abdominal distension history must have been obtained very, very carefully. That is it. Last but not the least, I never heard anything about the way the baby, you only said loss of weight. But what would I want from you? Not loss of weight. There's something else I would have wanted from you. A child who receives 15 transfusions in 2 years, what other questions I would have asked? I'm giving you a clue. I won't ask for loss of weight. I'll ask for what? I will ask for 3 things. 1, how is the weight gain of this child? Second, how is the height of
he
this
has given a lot of clue. Iron overload. Any
Yes.
symptoms you will specifically ask for?
Height
Which
of
organs?
weight, height, and I would have asked whether the head size is big. I would have asked whether there is any abnormal faces, abnormal teeth, maxilla protruding, right?
Yes, sir.
Those
Child
things.
is 2 years old.
Dysmorphism. Dysmorphism would have given a clue that it may be a storage disease. And a large head would have given me a clue that it may be thalassemia or even osteopetrosis. That can result in repeated transfusions.
Yes, sir.
Okay. And short stature, a storage disorder which affects the growth of the child, even if it is thalassemia requiring transfusion, it can affect the growth of the child.
Yes,
Short stature. Short stature. And coming to the other point about the child who requires transfusions periodically, well-being of the child, whether the child has been falling ill for any reason other than, has been coming to the hospital for reasons other than transfusion. Why is that important? How is that important, Dr. Aishwarya? I mean, it gives me a lot of information. They are saying that the child who attends the hospital only for transfusion, not for illness, that's likely to be something which is a chronic affair like the thalassemia. In contrast to a child who gets repeatedly into the hospital, in which case
Other cell lineages, involvement of other cell lineages.
Chronic disease. These are all not. So with this history, straight away, you know that this is probably a hemolysis. That too, if you had obtained a history of abdominal distension and a little bit of maxillary prominence and a large head, you could have straight away concluded this is probably organomegaly, this is probably an anemia, which is recurring again and again, which requires transfusion, which is not affecting the child in a great way other than causing anemia and fatigue and pallor. So you could have straight away come to a conclusion, this is hemolysis. And the hemolysis, again, the most common one, which requires periodically transfusion, is only a thalassemia. And thalassemia major, you can definitely vouch for it that this is thalassemia major. Or the only other possibility is that a combination of the thalassemia and sickle cell, both together. And straight away, you know that this is not thalassemia intermediate because it requires transfusion periodically, regularly. Okay, that's my comment. And I don't think I will entertain a diagnosis. The only other diagnosis, in fact, if abdominal distension had been absent, I'm giving again a clue. Abdominal distension absent, jaundice absent, but the child requires transfusion every, say, 6 to 8 weeks. What other diagnosis will you consider other than thalassemia?
If both abdominal distension and jaundice are absent.
No, I'm giving a clue. I'm repeating it. Same story, transfusion like this, no abdominal distension,
Sound is-
No illness no hospitalization for any other illness, but only getting the hemoglobin drops down, child gets admitted, goes back. Everything else is okay with the child.
We discussed.
And give a pure answer, undiluted pure answer. I'm giving a clue. Pure red cell aplasia.
Yes, yeah.
Pure red cell aplasia. That's the only other diagnosis I'll consider if there is no abdominal distension, no the maxillary prominence, okay, no jaundice, no family history. Pure red cell aplasia. Periodically, they will also require transfusions.
Pure red cell aplasia requires so many transfusions.
It may require, sir. Not so many, but at least once in 3 months, a child may, the hemoglobin may drop down and child may develop hemodynamic instability, though it's very rare. It's not common. It's not common. Okay. Last is in a child like this who has repeated transfusions. Of course, you could took the drug history. Again, if there has been no jaundice or hemoglobinuria, I think intravascular hemolysis due to something like G6PD or hexakinase is very, very unusual. Again, it doesn't cause this sort of periodic requirement for a transfusion. These are my comments. Thank you very much.
So points well taken, sir. So when there is, so what did you infer from the points, Aishwarya? One is when even if you don't have a proactive history, once you've finished your examination, go back to your history and ask the mother whether she noticed abdominal distension, because it will give you a clue right from your history itself. That is one thing. And always consider congenital anemias if there is no abdominal distension and jaundice. So when there is abdominal distension and jaundice, of course, it goes for hemolysis. Significant jaundice goes for hereditary spherocytosis. The absence, look for congenital anemias. And ask history for ruling out other cell lineages also. Okay. And as sir was telling, unlikely iron deficiency anemia will cause such amount of recurrent transfusion. Although it is part of routine teaching, probably if you get it more focused, we can skip all these history also. Okay, go on. Go to your next slide.
Past history, the child is on regular transfusions every 21 days since 8 months age and has undergone 15 transfusions till date. She is on oral medication taken every morning in empty stomach for the past 4 months, and she is on supplements.
So what supplements and what is the oral medication? Is it likely to do too?
The oral
Do
medication.
you ask more history for that?
The
oral medication is what?
Medication could probably an iron chelating drug. As the
what other history you will ask and the method they take it? How is it taken? It is taken in an empty stomach half an hour before food. That is okay. Other than that, very typically, what instruction will give them? How is it mixed? How is it administered?
It's fully diluted in a glass of water and
not in steel tumblers, because it is an iron chelator and it will stick to these. So usually we tell them to use a glass tumbler or a plastic, anything other than the steel tumbler. So if that history is there particularly, and it is taken once a day on an empty stomach, usually in the mornings or even can be in the evenings, then it is more likely to be because of an iron chelator. What supplements are these children usually put on?
They are given folic acid supplements. And
do they require folic acid supplements? Transfusion dependent, the child is requiring regular transfusions. Do we give in our hospital? Do you give folic acid for all of them?
Usually,
why it is required? Why it is required?
Why it is required?
Purpose. Why?
Increased consumption of folate due to ineffective erythropoiesis. And
more is the erythropoiesis, more is the requirement for folic acid. Right.
Excess consumption of folate leads to folate deficient state.
Right. Okay. Proceed.
So it is not given in children who are on regular transfusion, but non-transfusion dependent thalassemias. They are put on regular folic acids. Other supplements are usually given like vitamin D, zinc. All these are usually given because they are more prone for these nutritional deficiencies. So that those supplements will be important, especially when you're putting them on supplements. Always remember that most of these multivitamins, they contain iron. So when they're giving on supplements, you have to make sure that those preparations do not contain iron. So standard preparations, you have to make sure they don't contain iron. Okay. Go on. How is our compliance? You have to also comment on the compliance for the drugs, for the chelators, as well as for the transfusions. That is one important history.
The complaints good, ma'am. The mother is well aware of the child's condition. They are regularly on transfusions on fixed dates.
Okay. Always mention the complaints because complaints is a very big issue in any long-term disease, especially thalassemia. And iron overload is usually asymptomatic except in the later stages. So they will not mind to skip the medication. So always talk about complaints to the iron chelator specifically.
Coming to the antenatal history, the mother was married at 18 years of age. And this is the third child who was a spontaneous conception. And it was a registered and immunized pregnancy, no history of fever or rash, no history of any drug intake, iron folic acid supplements taken for 3 months, no history of medical complications or surgical complications, no history of antepartum hemorrhages, and no history of blood transfusions in the mother.
So Aishwarya, suppose you were the medical officer at the PHC and you have seen this mother in the first antenatal visit. Would anything in her CBC given her a clue that the child could mean the mother could be a carrier? Just a CBC?
First of all, the anemia would make me look deeper into the CBC for the RBC indices. Looking into it, there would be the Menser index would have been less
You
than.
do a Menser index. Antenatal mother is coming to you. Mother antenatal is coming to you, have a CBC. What clue will you get in the CBC to tell that the mother could be a carrier? There is anemia, hemoglobin is less than 7 grams. What will be striking to you?
The indices would be microcytic hypochromic with increased.
That is the
RBC
same in
count.
iron deficiency also, no?
RBC
very good.
count will be higher in people with thalassemia.
So if the RBC count is low and it is microcytic hypochromic anemia, more likely it is because of iron deficiency anemia. But if you see your count where the hemoglobin is low, the MCV is low, but the RBC count is normal or it is increased also, always think that this mother could be a carrier and this pregnancy could have been well prevented. Okay. Why did the mother take iron and folic acid only for 3 months? How long is she supposed to take?
How completed 100 tablets of.
How many tablets?
100 tablets.
That was initial, no? How many tablets of iron and folic acid we are supposed to take? Antenatal mothers. We start from at the end of this first trimester, you have to start, continue till the end of pregnancy. So how many days? 180 tablets, 180 tablets. So for the entire pregnancy, except for the first trimester, she'll be put on iron folic acid and 180 days even after delivery. That will be the usual schedule. Okay. Okay, go on. Next slide.
The data history, the child was a full-term normal.
If it is normal, we will have more time for problem. If it is normal, go ahead. Right. Skip the slide.
Okay, that is normal. So sir is telling skip it. Suppose the child had presented with hemolysis or jaundice, required rectal transfusions in the newborn period itself. What hemolytic disorder it must have been?
It could have been ABO or RH incompatibility.
No.
Other than blood
related to this type of disease.
Hereditary spherocytosis is present in the neonatal period.
Neonatal means on which day it can present? Earliest. Neonatal is a long time, 30 days, 28 days. And which day it may present? First?
Within first week.
No. First day itself, right.
Yes, sir.
Right.
Severe heterospherocytosis can present early. Even G6PD deficiency, some of the phenotypes can present with spontaneous hemolysis in the newborn period. Okay, go on, next slide.
Coming to developmental history, the child has attained all milestones appropriate for age.
Can we skip it? Can we go to the next slide?
Yes.
Yes, if it is normal, go. Right.
Coming to the diet history, the child was extensively breastfed up to 6 months and was started on complementary feed from the end of 6 months. As of now, by 24-hour recall method, the expected calories for this child is 900 kilocalories, whereas the child is getting 750 kilocalories, and the deficit is 150 kilocalories. And coming to protein requirement, the expected is 12.6 grams, and the child is getting 10 grams of protein with a deficit of 2.6
Suddenly
grams.
your voice is this thing has come down.
Talk
Yeah, you are
loudly.
audible suddenly, I think your energy level is coming down. Actually.
Or specifically, we'll ask in the diet history in a child with thalassemia requiring regular transfusions. Any method of cooking or something in the diet? Using iron utensils does now become even fashionable, and it will even be a routine in these village households. So we have to try to avoid cooking in iron utensils as such. And
Yes.
anything that we can encourage these children to take that we don't usually allow other children to take in the diet. Tea. Tea has tannins that can decrease the absorption of iron. So we can allow or even advise them to take tea. Okay.
Yes.
Next slide.
Family history of this child. There are no history of blood transfusion in other members of the family, and there is no history of unexplained deaths in the family members. And this is the pedigree chart for the past 3 generations. And in this child, the mother and father were found to have a milder form of this illness, and the other siblings were not affected, but this child presented with the major form of this illness.
What other family history is important? A child who is requiring regular transfusions, has mild jaundice. What other family history you will ask? This one, these people had been detected by screening after this index case had been diagnosed. Am I right?
Yes, ma'am.
Suppose any history, suppose you don't have a diagnosis.
Gallstones.
Yeah. History of gallstones, recent surgeries, history of recurrent transfusions in any of the members. You can point to the what diagnosis?
It points to spherocytosis.
Hereditary spherocytosis. That is one thing. So suppose this child, you are telling the other 2 children are carriers. And this child is requiring regular transfusions is 2-year-old.
No, I just want to know in the pedigree chart, just one doubt. She has drawn half black square and this thing off. And now she has mentioned all the siblings are also having this thing. That means they also should have half black,
Yes, sir.
Am I correct or not?
Yes, sir. Yes, sir.
Because you have mentioned specifically that siblings are also having. Okay.
Yes, sir. Sure.
What's your take based on this pedigree chart? What do you think? What is the suggestive of?
Autosomal recessive inheritance, where all generations need not be affected, and few of the offspring can also be spared from having the severe form
How
of
many
disease.
percentage? How many percentage will become carriers?
50%
50% of them.
will be affected. 25% will be carriers.
25% will be affected.
25%
will be carriers, and 25% will be normal. That is for autosomal recessive inheritance. So suppose this child I'm planning for stem cell therapy, and I'm screening for these all the first degree family relatives, and the elder sibling has a perfect match. Will you allow for stem cell transplant or not?
No, you enlighten, ma'am. You enlighten.
The siblings are carriers. So you can allow stem cell transplant from a carrier So in that case, this child will convert from a TAL major to a carrier state. So again, the transfusion requirements will come down dramatically, but again will become a carrier state. So even if they are carriers, you can, if they are 100% match, the success of a stem cell transplant only comes with the matching 100% HLA typing. So if it is a good match, then even carriers can be taken up as donors. Can the first degree relatives transfuse or donate blood to this child? Will you ask the father or mother to donate? They are willing.
Yes, ma'am. The transfusion committee.
Okay, they can give, but what is the risk? I'm planning for stem cell. This child definitely we must have worked up for stem cell therapy. What is the risk if a first degree relative donates blood? There is a risk of alloimmunization, and there is a future risk of transfusion related graft versus host disease once you transplant or a transplant related GVHD. So it is better, suppose you're planning for stem cell therapy, try to avoid transfusions from first degree relatives. Okay, next slide.
With immunization history, the child is.
We'll go ahead. We'll go ahead. We'll save time for actual discussion. You are doing correctly, but still, right.
Yes, from history, it can be summarized as it is a 2-year-old female cell, third born of non-consanguineous marriage, with history of pallor noticed since 7 months of age, and history of regular blood transfusion since 8 months age. Probably the system involved is hematological, and the probable diagnosis is a chronic anemia of hemolytic etiology.
So here you can still have a differential diagnosis because there is no history of organomegaly in the form of abdominal distension. There's no history of jaundice. So it can still be congenital anemias, although the presentation is little late from 8 months. So you can say I'm giving a differential diagnosis. One is because of hemolysis, and most probable being thalassemia, transfusion dependent thalassemia, major thalassemia, or it can even be some bone marrow failure syndromes or congenital anemias, or even osteopetrosis will have abdominal distension. Bone marrow failure can also be, decreased production can also be a differential diagnosis at this point. Okay. Okay.
That's a very good point here, madam, that you have mentioned that, that abdomen is normal. If it is thalassemia with so many transfusions, invariably you'll find some degree of distension of abdomen. Okay.
Okay. Go on to the examination.
General examination, the child is alert and playful, afebrile, pallor present, no icterus, no cyanosis, no clubbing or pedal edema or centralized lymphadenopathy. ECG scar seen.
Qualify the pallor. How was it significant? It was severe or some pallor?
Some
pallor,
pallor can be seen in palpebral conjunctiva, palms and soles, and nail bits.
Okay, where did you see, and can you classify pallor just by looking at it?
Yes,
or where it is recommended to be seen?
Recommended to be seen in palms in comparison with the hands of examiners, provided examiner is not anemic.
Okay, very good. Then you should have classified the pallor, no?
Severe pallor means there is
no, in this child, whether it was severe pallor or it was some pallor.
Some pallor.
It was only mild degree of pallor. Okay.
Yes.
Okay, go on.
Dr. Aishwarya, whenever you have pallor, try to ascertain probable underlying cause. Whether it is nutritional, if it is nutritional, whether it is iron deficient, not related exactly to this case. You try to see there is no other system to separately describe, the only 4 major systems. So whenever there is pallor, try to find out cause for that pallor. Not only in this case, in any case when there is pallor. Look for signs of iron deficiency anemia. Where else we will see, if not in general examination? Signs for megaloblastic anemia, like that, okay? Any findings, rather, signs means any findings. Right.
Okay, next slide. Go on,
Coming to vital signs, temperature was 37 degrees Celsius, pulse rate 100 per minute, regular rhythm, normal volume, and no special character. And all peripheral pulses felt equally with no radial or radius abnormal relief, no pulse deficit. Respiratory rate 30 per minute, abdominal thoracic type and regular. Blood pressure 90, bar 60 millimeters mercury as measured in right arm in supine position using appropriate sized cup. Saturation was 99% in room air.
Go on.
Coming to anthropometry, the height of the child falls between 0 to -2 standard deviation, and it is suggestive of no stunting. Weight of the child falls between -2 to -3 standard deviation, and this is moderate thinness. Weight for height falls between -1 to -2 standard deviations, and there is no wasting. Mid-upper arm circumference -2 to -3 standard deviations, indicative of moderate malnutrition. Head circumference is 47 centimeters, which lies between 0 to -1 standard deviation, and which is normal for this age.
Dr. Aishwarya, we generally expect some growth retardation. What prevented the child from going into growth retardation?
Complaints and
No,
regular.
before complaints is in part 2. First is early diagnosis, timely transfusions, right? Then complaints.
Yes,
Right.
Go on. Next slide.
Coming to head to foot examination, there was a frontal bossing, flat nasal bridge, and malar prominences. Oral cavity was normal, skin normal, limbs and chest were normal, abdomen distended, genitalia and spine normal.
So is the child has malar prominence?
Doesn't look much.
Yes.
The appears almost flat.
Yeah.
There is not much of malar.
Doesn't look like.
What would you look for in the oral cavity?
Crowding of teeth would be present.
In this child, this is a 2-year-old, no? You said.
Yes, ma'am. 2 years.
What did you look for in the oral cavity in this child?
We can look for glossitis or
Okay.
cheilitis.
Other vitamin deficiencies should we always look for glossitis, cheilitis. Okay, then in Fanconi's, there will be a lot of hyperpigmentation, both in the skin and in the tongue. There will be a lot of hyperpigmentation, black coloring that can be seen in the oral cavity. Both of these. Suppose sir said one important differential diagnosis, that is osteopetrosis. What clinical examination would give you a clue? Suppose I'm telling this is osteopetrosis, how will you refute me? Suppose the child had abdominal distension, there is hepatosplenomegaly, child is requiring transfusions every month, which is very typical of osteopetrosis. What is against osteopetrosis in this child now? They'll have growth retardation, blindness and hearing loss. Because all the bony cavities gets bigger and all the nerves gets trapped in it. So they will go for blindness. They will have searching nystagmus by 6 months of age. Blindness and hearing loss are very, very prominent by the child before the child comes at even as early as 6 months. And it is a condition which is amenable to bone marrow transplant. And you have to pick up these children before they go for blindness and hearing deficit. So any child presenting with massive hepatosplenomegaly, recurrent transfusions, always have osteopetrosis in your mind. Okay. In spine, what did you look for? In limbs and chest, what did you look for?
Limb deformities, there are deformities of absent or extra digits can be present in aplastic
Fanconi's anemia. Then in diamond blackfan, you can have thumb abnormalities, triphalangeal thumb. That can be present. Diamond blackfan also has a typical phages, white spaced eyes and snub nose, or that can be present. What is the reason for this frontal bossing?
It is extramedullary hematopoiesis.
Not extramedullary. It is because of medullary hematopoiesis.
Medullary. See, that's a common mistake. Many people say extramedullary, right? Many people, not only you. It's a standard mistake, right?
That is why we also asked the question over and over again. So it is in the bones. It is medullary hematopoiesis.
Medullary hematopoiesis.
So the flat bones get enlarged to look like this.
Okay. So what is this facies called as?
hemolytic facies or cherubic chipmunk
Cherubic.
facies.
Chipmunk
Chipmunk
facies.
facies.
Okay. Okay, go on.
Just a
would like
minute,
to-
just a minute. Dr.
Yes.
Srinivasan, followed by Dr. Bala, your comments.
Here, of course, the abdomen is so distended.
No, so far, what she has covered so far.
No. Yeah. I think she has been this thing. Only thing, there is a triangular face, but of course, as Bala has asked for, the frontal bossing is very much there. So definitely the forehead is markedly this thing, and the hairline is receding. So, yes.
Dr. Bala, please, quick comments. Right. Sir.
If see, two things are obvious. One, this child is growing reasonably well, but there is something which is importantly observed in the anthropometry. The head circumference is a little larger than what you expect in a child whose weight and height are below the centile. That indicates probably one more clue to the widening of the diploid spaces in the skull and the skull being large. That is one. Second is, because if I had seen this child without any history, I would say the face is essentially okay, except for epiculorism. Of course, I can't see from the side whether there is any malar prominence. The profile, frontal profile, to me, it looks fairly.
Yeah. Malar prominence is not there, but definitely frontal bossing is there.
Definitely, I have to see from the side and just confirm whether there is frontal prominence. And definitely, you should have commented on the fontanelles of this child. Because, as Dr. Kalpana pointed out, one diagnosis which is very, very costly, which can be made clinically, is osteopetrosis. Even without X-ray, you can say hepatosmegaly, anemia, searching nystagmus, child who has a large head and probably a bulging fontanelle. The fontanelles are open. You should have commented on the fontanelle. Of course, I expected you to say that the fontanelles are closed, right? And they are not palpable. That's my only comment. Rest is all fine. And of course, some mention could have been made about the overall activity of the child. Because, any child who's got anemia, particularly who's got severe anemia, the infant's attention span, the child's attention span is likely to be lower than normal. But one of the symptoms that the child's hemoglobin is dropping down, in addition to the breathlessness noticed by the mother and the pallor noticed by the mother, and the fatigue and easy fatigue noticed by the mother, is again behavior change. It's not only iron deficiency anemia, any anemia will cause, of course, iron deficiency notorious for causing decrease in attention span more than other anemia. Any anemia will cause a decrease in attention span. These are my comments. Thank you.
Proceed. Move on.
Coming to systemic examination, I would like to examine the abdomen first.
See, Dr. Aishwarya, unlike surgeons, we examine systems. We shall start with oral cavity, respiratory from nose, CVS from the neck, like that. Okay, surgeons examine locally, we examine.
Also, the picture of the hands would have been important because, sometimes the ductility with that they'll be enlarged. So, and of course, the face doesn't look so pallor because of the repeated transfusion. Okay, these children, they have a typical thalassemia major. They have hands, their phalanges are very much enlarged, so it's very remarkable. You could have taken a picture of the hands. Okay.
Right. But for pallor, oral cavity is normal.
Oral cavity.
But for pallor is normal.
Yes, sir.
No other abnormality. Okay, proceed.
They mentioned something about the teeth, color of the teeth also. It's very important to look at the color of the teeth.
Where the teeth?
Color of the teeth.
Why he's saying so?
Number is also important. Number, carries, color, all these things should be mentioned routinely. Often we don't do that. It should be done in general examination.
Yes, sir.
Proceed.
Inspection of the abdomen, distended, flanks free, umbilicus inverted and in midline, skin over the abdomen normal, no dilated veins or scars or sinuses, no visible pulsations or peristalsis, perineal orifices free.
No, when you say
Still
there
want to
is
say this
distension,
umbilicus is midline?
that's what I'm telling. Once there is distension, you always try to tell whether it is generalized distension or is upper abdominal distension or lower abdominal distension. And the distance, how is the umbilicus? The distance is it equal from Xiphisternum to umbilicus and umbilicus to pubis. So it's very clearly upper abdominal distension, which indicates that it is probably splenohepatomegaly, right? Hepatosplenomegaly,
Yes.
right?
Yes.
And it is supported by the distance between the Xiphisternum to umbilicus is more than what it is below, right?
Yes.
Always say whether it is uniform distension or confined to a particular part of the abdomen, which gives an important clue, right?
Yes, sir.
Go on.
1 minute, please go back to the picture. Go back to the picture. See, two things, Dr. Aishwarya. It's
Yes,
not enough if you simply say abdomen is distended. There are so many findings in this abdomen, I can tell you straight away. One, if you see carefully, because you have taken a camera view from the left, a tilt is not straight. The abdomen is distended and it's not uniform distension. It's more, as Dr. Ramakrishna pointed out, the distension is more upper abdominal than lower abdominal. The distension to me looks like it's more on the left than on the right. And the umbilicus is not only, why do you say inverted? I don't think it is inverted. It's actually protuberant, and it is pushed down, and the umbilicus is transversely stretched, pushed down. And I would also say, I don't know, it is seen from the left side. I'd also looked at whether it is stretched towards the right or left. And as I said earlier, this much of abdominal distension, the mother would, if you ask her, she will tell you the abdomen has been like this only for the last 1 year and it is worsening. That's what I mentioned in the history. In fact, even without touching, you can say that this child has got a splenohepatomegaly, more splenomegaly than hepatomegaly, and probably there is no ascites because it's not uniform distension. Okay, and this doesn't seem to be a renal mass. Looks like a splenohepatomegaly, which is pushing the abdomen down and stretching it.
Sure, the liver will be almost 8 centimeters below the costal margin, and the spleen will be about 3 to 3/3, almost touching the umbilicus.
Yeah.
Yes.
And I don't see any veins. Yeah, as you rightly pointed out, there are no veins which are visible. And I don't know, I can't see the side. I don't know whether there is any chest deformity in the side. Okay, it looks a little bit, because it looks like there is some chest deformity also on the sides. Okay, thank you.
You would have asked the mother whether the abdomen was like this for the last 1 year. That gives the answer. She may think it is normal, but if she says that this is like that only for the last 1 year, that means she missed the distension. And it was there for the last 1 year. Okay? Or 6 months or so. Proceed.
Yes,
Proceed.
Palpation of abdomen, no warmth or tenderness. Liver was palpable 3 centimeters below the right costal margin, along the mid-clavicular line, moves with respiration, firm in consistency, round margins, smooth surface, and non-tender. Spleen palpable 2 centimeters below the left costal margin, along its long axis, firm in consistency, not tender, splenic knots felt, moves with respiration, not palatable, not bimanually palpable, not able to insinuate fingers into the costal margin, and no fluid thrill.
Go on.
You may say abdomen is soft, no other mass is palpable. It's not that only liver and spleen can be enlarged, isn't it?
Yes, sir.
Maybe in a case of leukemias and other things, apart from this visceromegaly, there can be lymph node enlargement also in lymphomas and all. So make it a habit of saying there is no other mass and say the abdomen is soft. That is important. So there is no acute condition. And comment on the posterior abdomen also. Abdomen is not only to the anterior side, but also to the posterior side. May not be relevant in this case, but for being systematic in presentation. Right.
Yes.
Sir, two comments. One,
Yes.
once you say spleen is palpable, there is no need to say moves with respiration, not palatable, bimanually palpable.
Yeah, at her age and study period.
It's redundant. You have said it's spleen. Unless the examiner asks you how you say spleen, you don't have to mention. That is my
Yes,
comment number one.
Not for a postgraduate, you are right, sir. For undergraduate, yes.
Comment number two, I don't think a spleen which is palpable only 2 centimeters, you will be able to feel a notch ever. There's some mistake in the calculation of the splenomegaly. It has to be much more than 3 or 4 centimeters for you to palpate the notch. You can't get a notch with the spleen being
Exactly.
palpable only 2 centimeters. I have never seen. I'm sure Professor Srinivasan would agree with me.
Absolutely. Yeah.
Not to
At
doubt your
least,
measurement, right?
At least it must be beyond 2/3, no, in between this thing, below the. Yeah.
Dr. Aishwarya, not to doubt your measurements ability, if they are just 2 to 3 centimeters on either side, you wouldn't have observed that much of abdominal distension on simple inspection. Even in the photograph also we are identifying means it shall be more than 3 centimeters this side and 2 centimeters that side.
Yes, sir.
Right?
Yes.
Right.
I don't think the picture she shows is consistent with the splenomegaly of 2 centimeters and
Size and
hepatomegaly.
the picture, they don't correlate. Right. Proceed.
Yes. By percussion, the liver span was found to be 7 centimeters and no free fluid, auscultation, bowel sounds here, and no abdominal brewing.
Okay.
Other system examinations, cardiovascular system, the first and second heart sounds heard normally, no murmur. Respiratory system, bilateral RNT, no added sounds. Central nervous system, there is no focal neurological deficit.
Dr. Aishwarya, again, I am interrupting you. What is the most important finding you would like to look for in CVS? It is not the sounds. It is not the murmurs primarily. What do you look for primarily in a case of such presentation? What is the findings you would like to look for? Which you are going to treat? Huh?
Epical impulse.
No. What is the one which you are going to treat if it is there? You don't treat you have to mention the sounds, you have to mention about the murmur. Accepted. We have missed the elephants, camels and elephants. What you are expected to see, most importantly in CVS, the child presenting with pallor. What is the complication when there is severe anemia?
Congestive cardiac failure.
You tell about JVP. You will tell about JVP. Without there being congestive heart failure in the early phase also, because it's volume overload, it may result in dilatation of the chamber. Okay. So those are more important than heart sounds and murmurs. Okay, there may be a murmur if it is severe, a functional murmur. That is not all that important. See, the finding should be either to help us in diagnosis or guide us in management. Right? When there is failure, we are in a hurry to treat it. Right.
Yes, sir.
And regarding the respiratory system, never say bilateral air entry is present. It is only for anesthetists. If the air entry is there on both sides, they are comfortable. For us, there are many areas. So instead to say simple, there is nothing like there are only 3 heads. One is breath sound character, VR, and infectious sounds. You may say, instead of saying bilateral air entry, proceed. Because many PGs are following you. That's why I had to correct even small things. Yes, proceed.
Coming to the diagnosis, the child, here's a child with transfusion-dependent anemia and hepatosplenomegaly. Diagnosis is a hematological disorder, probably beta thalassemia major.
Can you substantiate your diagnosis?
First of all, the age of presentation of this child is beyond 6 months, which is the usual presentation of thalassemic disorders. And it is the child has
just a minute. It's a genetic one. Why it doesn't present earlier than 6 months?
At the end of 6 months, there is a transition from the fetal hemoglobin to adult forms.
No. It doesn't present before that. What prevents it getting manifested? What prevents the manifestation with signs? Yes, you are right. You just elaborate.
The
What
beta
chains?
chain, beta chain is not needed during for the formation of HbF, which is found for the first 6 months. Beta chain is required only after 6 months of age, when hemoglobin A2 needs to be synthesized.
Okay.
It is not completely absent before 6 months. It continues to rise from term. Even a term child will have some amount of hemoglobin A. If there is complete absence of hemoglobin A in your first, even the newborn period, that itself can be a clue that this child could be a thalassemic child. So hemoglobin A in a normal child will be present till term, but reaches the adult hemoglobin levels around, the complete switch occurs around 6 months. So that is when the full manifestations of the disease take over. So one is the age of presentation, then
Just a minute. What is the clue in newborn screening to say that it may be a case of thalassemia in newborn screening?
can you detect thalassemia newborn screening?
Hemoglobinopathies you can diagnose in newborn screening. And what's the clue? Ma'am, you may enlighten in a better way.
So as I said, thalassemia cannot be detected in newborn screening because the only thing that we have is only HPLC to diagnose even in newborn screening. So if there is complete absence of HPA, and if you do it proactively, then probably we might think it might be a case of thalassemia. But sickle cell anemia can be detected in newborn screening because you have hemoglobin S. So that will be detected in HPLC and isoelectric focusing.
That's why I'm asking hemoglobinopathies. I change it from thalassemia to hemoglobinopathies. Yes, Karen ma'am, you are asking something. You are
So
asking
substantiate. One is the age of onset, then
The number of transfusion the child has required, dependent on recurrent blood transfusions, and from the examination part, abdomen distension and organomegaly with
splenohepatomegaly. General examination, nutrition, everything you should say.
yes.
You have findings general examination.
From general examination, the facies of the child points towards hemolytic cause, and from system examination, the splenohepatomegaly, all this put together contributes to diagnosis of probably thalassemia.
To complete your diagnosis, you left out nutrition. Was nutrition normal?
The child was in moderate thinness.
So there was moderate acute malnutrition. So nutrition is a very important component in thalassemia because suppose there is growth failure, what does it tell you? This child is not being adequately transfused. So that is an important indicator. If there is nutritionally the child is better, but the anthropometry is low, growth failure per se tells you that the child was not adequately transfused. So this child is reasonably well, but don't leave out nutrition in any case. So that is one thing. Second is they'll talk about compliance to blood transfusion as well as to compliance to chelators. Of course, if it's an older child, we'll also talk about the presence or absence of complications of the disease. But since this is a young child and 2-year-old, we are not expecting any complications of thalassemia to manifest. Okay. So how do you approach this child?
Investigations part. First, I need to do a complete blood count.
Yeah, go on. What we look for in the suppose it is just the first time you're seeing this child for the first time. What will you do and what will you infer?
First, I will do a complete blood count for hemoglobin levels and RBC count, and peripheral smear examination.
Talk about CBC. What we look for in the CBC?
CBC, the hemoglobin level. If it is less than hemoglobin level less than 7, indicates the need for urgent transfusion.
No, it's for diagnosis. We are at the diagnosis.
For diagnosis, that is anemia, and then
not for management and treatment.
Other RBC indices.
There is microcytosis, decreased MCV, and decreased MCH. RBC count is relatively higher for the amount of anemia. And coming to WBC count, the counts can be increase leading to spurious lymphocytosis because
Not lymphocytosis.
the
Okay, tell me, complete.
because the ineffectively produced RBCs are counted to be WBCs, so there is a
So the
abnormally
normoblasts have the same size as the leukocyte. So all those normoblasts which are in the circulation will be counted as WBC. So it may have a WBC count of 40,000 and 50,000. Sometimes might prompt you to think about malignancy, but always remember in a child like this, it can just be normoblast. Okay, then
coming to the platelet count can also be spuriously high, amounting to the fragmented RBCs can sometimes be counted as platelets.
yes. Yeah. Then
Um,
talk about the restal distribution with RDW.
there is this RDW is lesser, is expected to be lesser in this child, and there is it is
In contrast to
iron deficiency anemia, where it is higher.
Why it is high in iron deficiency anemia?
Variations in the sizes and shapes of RBCs
Okay.
are more in thalassemia.
Anisopoikilocytosis, RDW will be. What will be the retic count?
Retic count, it can be higher.
but not to the expected higher levels because of
Again, ineffective erythropoiesis.
It can be higher.
So the clue comes in the RBC count, the MCV and the MCHC. Although we don't do retic count or corrected retic count routinely, but it can be done. It can be got in the CBC counter itself. RDW again can be got from the CBC. So all these can give you a clue whether it is a hemolytic disorder that is going on. Okay. Then
yes, if you have investigations, you have a slide on investigations, Dr. Aishwarya?
next slide.
Last slide, or you have any more slides? Just
Is there
project.
a peripheral smear picture of this child? No.
I have not given.
No, this is the last slide, is it?
Yes, sir.
No, for hematological condition, you could have put the investigations also. The image of the peripheral smear like that. Okay. For other cardiovascular and all those things, investigation may not be all that required. But here, hematological is one which we can confirm by seeing
The peripheral smear target cells are seen, many.
Yes. What do you see in peripheral
And
smear?
Menzel index was calculated.
Yes, sir. Peripheral smear target cells are characteristic of thalassemia, and there are microcytes with increased central pallor. There can be fragmented RBCs also.
So there is microcytes, hypochromic. Target cells are typical, but they're not very characteristic of thalassemia. But target cells are very typical of hemolysis. They tell you that there is hemolysis. You can see fragmented RBCs can be seen in the peripheral smear. Okay. Nucleated RBCs can also be seen. Okay. So you confirm the diagnosis?
Confirming the diagnosis, reasonably.
HPLC is the confirmatory investigation for thalassemia.
What will be the hemoglobin pattern in thalassemia major?
Percentage of HbF more than 80%.
A will be very low. So it can be 0 to 30%. And A2 will be
around.
It will be elevated, slightly
more
elevated.
Than 3.5.
Okay, it will be more than 3.5. How will be the hemoglobin pattern in the HPLC pattern in the siblings?
Their traits, the HbF level would not be up to 80%. It will be less than 80%. But
how much? Less than 80? How much it is usually? Can it be 60 and 50?
If normal is 1%, so it will be around 50%. It
will be slightly elevated, 0.5 to less than 4%. But the clue comes from the elevated hemoglobin A2. that will be more than 4 to 8%. If the cutoff will be usually taken as 3.5%. If it is increased more than 4 to 8%, that will be a clue to thalassemia trait. The hemoglobin A can be normal or can be decreased even if there is coexisting iron deficiency anemia. So that will be the part. The clue will be coming from hemoglobin A2 for all these carrier states. Okay.
Yes, ma'am.
Okay.
Which
For
is
this
more
child, what will
confirmatory?
you do?
Which is more confirmatory test than HPCA?
Suppose you have
Genetic
transfused this child.
Genetic analysis is more confirmatory.
DNA, right? DNA analysis, right? Because time is running short. Treatment, a few points on treatment.
Yes. Regarding this child, first, nutritionally, this child has to be managed. Adequate nutrition and with supplements. Anthropometry should be monitored in every visit and to be counseled for regular blood transfusions.
How frequently you'll monitor anthropometry?
Every 6 months.
Every 6 months. Height, weight, and older child, pubertal assessment every 6 months, and the sitting height. All these four will come under anthropometric assessment every 6 months. Okay.
Yes, if the child is on regular transfusions, the monitoring of serum ferritin levels is essential. And
when will you start monitoring for ferritin? After
3 to 6 months.
15 units of transfusions or 15 transfusions, you will start monitoring for ferritin. And if the ferritin is more than 1000 micrograms, you can start the child on iron chelators. Okay.
Generally, what will be the time period you start chelating agents, roughly? Suppose you don't have so much of good monitoring.
Around after 10 transfusions.
After 1 year or around, right?
Yes,
right. Yes, carry on. So what is the precautions you take in selecting the blood compared to other blood transfusions? What extra precautions you take?
You're transfusing for the first time, what and all you'll do?
Leukoreduced, leukodepleted.
Transfusing. Before transfusing, what and all you'll check for?
Screening the blood for infections like hepatitis B.
In this child, a thalassemia major child, you're transfusing for the first time. What and all you'll do? You'll check for an extended red cell antigen typing, because minor blood group incompatibilities can cause severe hemolysis and alloimmunizations in this child. So we have to look for ABO and myelogroup groups like the DEL and KEL and Duffy should also be typed, including RH. Everything has to be typed. That is extended RBC antigen. Suppose you have transfused, they even advise a phenotypic or a genotypic panel analysis to type the RBC antigens. That is one thing. What type of blood will you select? Okay, you're talking about leukodepletion. What is leukodepletion?
What is the purpose? Why you go for leukoreduced?
Remove the antigenicity.
What do you reduce? Leukodepletion is removing the WBCs, white blood cell. Yeah. Why do we leukodeplete? What is the reason for leukodepletion, and how will you leukodeplete? What is ideal?
Irradiation.
Irradiation. Leukodepletion is by using either a pre-storage, they use a filter in the blood bank. Before even storage, they will reduce the WBCs. Or if that is not possible, then you can use a filter when you transfuse the blood, where you can reduce the WBCs, can be reduced. So WBCs in the blood will again increase your risk of alloimmunization, and the risk of non-febrile hemolytic reactions are also very high if you have high amount of WBCs. So you have to ideally give leukodepleted blood for these children. What is the ideal age of the blood that you're going to get? Should be less than
2 weeks.
2 weeks, at least less than 2 weeks, with a hematocrit of at least 0.65. How early or how fast you should transfuse these children? How fast you should complete the transfusion? Within
4 hours.
4 hours from getting the blood from the blood bank, because these blood are stored. Once you get it from, if you store it more than 4 hours, again it will go for hemolysis. So you have to finish off the transfusion by 4 hours. How soon you can finish off? Suppose this is a stable child, not in failure. Should you transfuse the blood for 4 hours or you can complete it earlier? You can even, current guidelines say you can even complete it by 2 hours. In a stable child, complete it by even 2 hours. What is the, how you calculate the requirement of blood? How much blood that is required? In a this is a well-transfused child. What is the pre-transfusion hemoglobin target that you're planning to get?
It is usually 7. It's an indication for transfusion.
Pre-transfusion hemoglobin target.
Target. Pre-transfusion target.
9.5 to 10.5 is the pre-transfusion target. Okay, how will you calculate approximate amount ml per kg of blood? Suppose it's a well-transfused, pre-transfusion is always 9.5. What is the usual ml per kg that is required of PRTCs?
It is calculated using the formula constant 3.4 into hemoglobin deficit. Into weight
usually
of
if it's well-transfused child, the calculation is just based that if you want to increase by 1 gram, you need 3.5 ml per kg of blood. So depending upon that, you can calculate. But it's a well-transfused and you know this child, the pre-transfusion is from 9.5 to 10.5. Usually will require 20 ml per kg. The usual transfusion rate is 5 ml per kg per hour. And if the child has very severe anemia or congestive cardiac failure, the rate will be 2 ml per kg per hour. Tell me something about transfusion reactions. What are the common transfusion reactions that you will that can happen?
Acute febrile reaction.
Okay, febrile hemolytic reactions. Then
transfusion associated lung injury.
Okay, it's more common in platelet transfusions, but we haven't seen so far. Then it can be allergic bacterial contaminations can occur. You can have fever and persistent hypotension. You can have anaphylaxis, or you can have febrile hemolytic reactions can also occur. Okay, what are the things that are usually screened for in before transfusing in the blood bank? What are the infections that are routinely screened for?
Hepatitis B.
Yeah.
HIV.
Yes. Hepatitis C, malaria, and syphilis. These 5 are routinely screened for, but most of them, remember, it is only scar test, and we have still a high carrier state of hepatitis C in these children who are chronically transfused. But routinely, we have to transfuse against in check for all these 5 viral infections. I mean, all these 5 infections. Okay. How will you monitor these children?
In
anthropometry. In this child, you said anthropometry. Okay. Every 6 months, what will you every visit? What will you monitor? In this child, tell me in this child.
Every visit, HB level should be monitored.
Then pre-transfusion hemoglobin. Will you monitor post-transfusion?
Yes, ma'am.
Not required routinely. Suppose you're properly transfusing the child, the compliance is very good, then pre-transfusion hemoglobin is required. Post-transfusion is not required. Then
child is on iron chelator for the complications like
you have to monitor for SGOT, SGPT, urea and creatinine. If the child is on deferriprone, if the child is on deferriprone, you have to monitor for the CBC counts, WBC counts especially. That is one thing. And then every visit document the liver size and the spleen size. Every visit document what is the amount of blood that is going to be transfused. And every visit document what is the next time or date of transfusion. This has all these has to be done for every month transfusion. Every 3 months you have to document the ferritin levels. And every 6 months document the anthropometry, calcium and phosphorus. And once a child crosses more than 5 years, you have to monitor for the complications, especially what and all you will monitor for the complications. Yearly monitoring, what and all you look for. You will screen for
iron overload.
That we are screening, okay. That we are doing with ferritin. What else you want to do for screening iron overload?
In chronically transfused children, MRI can be done.
Very good. At what age you will do that?
10 years of age.
So usually in the second decade, starting from 10 years of age, you can start screening for cardiac iron deposition and the liver iron concentration by using MRI. Any idea on how much the liver iron concentration should be there? Any weight, it's usually maintained less than 7 milligrams per gram of dry weight of the liver. And cardiac MRI usually should be maintained less than 20. T2 weighted MRI should be less than 20 milliseconds. If it's more than 20 milliseconds and the heart is not relaxing properly, that indicates the child can go in for complications like congestive cardiac failure, and that has to be. Suppose you diagnose cardiac iron overload, what will you do now? Child is on regular chelation with deferoxamine.
We start an IV iron chelation with
IV or what else? How is it administered? What iron will you give? What iron chelator is then used?
Desferoxamine.
Desferoxamine is administered by
IV or IM route.
Subcutaneous. It is administered by a subcutaneous pump over 16 to 18 hours a day. 16 hours a day. So it is administered by a subcutaneous pump. It costs around some 30 to 40,000 rupees. That is how you administer desferoxamine along with deferoxamine, because both of them have different mechanism of action. That is called shuttle therapy. Use both to break down the iron from the ferritin and then also to excrete the iron in the urine.
What is the definitive treatment?
Hematopoietic stem cell transplantation.
Do you recommend this in this child?
Yes, sir.
What are the things which preclude bone marrow transplantation? What are the things which are against for doing hematopoietic stem cell transplant? What are the things that are not in favor of going for hematopoietic?
Only consider as high risk for doing stem cell transplants.
Child is not transfusion dependent. Non-transfusion dependent thalassemia doesn't warrant.
Exactly. We won't go for a transplant. No. We are
the
going to
child
do
is
it
not
only
at
for
the
transfusion.
need for it. There is no need for it.
So child is transfusion dependent. Any risk factors for poor prognosis? What is the Leukerelli classification? The liver size. The liver size is more than 2 centimeter. The presence of fibrosis by a fibroscan, or if there is evidence of poor iron chelation, and all these are they are classified as high risk. And the outcome is very poor when compared to the first two classes. But if there is good chelation, any age you can do, any age you can go, and there is good compliance to transfusions, you can go for stem cell transplant even at a slightly older age also. Okay. So anything else?
Dr. Bala sir, your final comments?
No, very nice presentation, brilliant discussion by Dr. Kalpana. Not only Aishwarya learned, I also learned something more about thalassemia. It's a very nice presentation. Well done, Dr. Aishwarya. Keep it up. Well done, Dr. Kalpana. In fact, thalassemia is one of the most common long or short cases kept in the exam. And you must be very sure about the findings. As Dr. Kalpana was asking questions, the examiners always ask several questions. There is a good paper in Indian Pediatrics on frequently asked questions in thalassemia by Dr. Agarwal, if I remember correct. And also there are guidelines given by the Indian Association of Pediatric Hemato-Oncology. Please go through that and prepare for because it's an easy, straightforward case. So you have to be thorough with the theory part. There's not much in terms of discussion clinically, but there are not going to be many findings in such children. Okay, thank you very much.
Dr. Srinivasan, your comments.
Yeah, Bala has already mentioned. Of course, she has answered all the questions and well prepared. So, of course, Bala has mentioned that Indian pediatrics commonly asked questions, some 52 questions are there in that article, Indian Pediatrics. You kindly find out exact year, I forgot. So all the commonly asked questions are totally covered. So you can go through that. And of course, you must have listened to so many classes by our rheumato-oncologist, Scott, Julius Scott. He has taken in so many platforms, beta thalassemia and this thing. And Dr. Janani has given a lot of talks in Chennai platforms. So, of course, very well covered and very well discussed. Thank you so much. It's definitely an examination case in DNB. And of course, in Chennai also, there are so many cases of thalassemia. So it will be kept as examination case.
Dr.
Of course.
Aishwarya, you have done well.
Yeah.
If you had taken out the element of that anxiety and tension.
Yeah.
Tension,
Only thing you
have
are looking a
grade
little
very
as if you are being, grilled in examination. So it should
You
have
take
been
out
a
that
little
element
more.
of
Of course, I
stress
can
and
understand your
anxiety.
tension.
Yeah,
But
you
of
can do
course.
far better than this. You have done well. All the best, Dr. Kalpana. Really, you have done very good job and enriched all the audience. Thank you.
Thank you, sir. Thanks for
Right.
the
Thank
opportunity,
you. Thank you
sir.
very much. Dr.
Right.
Kalpana, you have, of course,
Good night.
well, thank you so much.
Good
Thank
night.
you.
Thank you.
Thank
Good
you.
night, all right.
Good night, all of you.
Right.
Thank you.